Did you time it when you wrote all this? Your
Yes, sir.
answer?
I read and learned and read. Sir. So
No,
I
no.
took
When
nearly 2
you
hours to write this.
no, what I am asking is, did you find out how much time you took to write all this information?
Sir, that's it, sir. I read and learned and I wrote, sir. So it took me
Yeah,
a
yeah.
long
You
time, sir.
learned and wrote. I'm not asking you whether you wrote from the book or
Two
from
and a half
your.
hours. 2.5 hours it took, sir, to read and
You took two.
simultaneously write.
Yeah, you took 2.5 hours to write. But we are now practicing you all for writing your answers in the theory paper. Okay.
Yes.
Of course, this I won't blame you. This is an excellent presentation for all the postgraduates to learn what are the pathological changes that happen in obesity. Every minute detail you have given very well. But our point is here is to, of course, this is will add to the knowledge of everyone. But at the same time, you must practice in such a way that you are able to finish question answer within 20 minutes time in your examination. So you have to abridge it as much as possible, because if questions are asked after you present, then you can elaborate and come out with a detailed answer during discussion, which is not going to affect your theory practice training. So the aim of all the postgraduates to prepare your answer is to present the answer which you will be able to write in your exam within 18 to 20 minutes, because you only have that much time. You are 3 hours, you are given 10 questions, so 180 minutes you have 10 questions to write. So each question has only 18 minutes time. So within that 18 minutes, you have to give the maximum very important points and complete your answer. Of course, this is an elaborate answer for very, very important knowledge all the PGs should learn for their future career as well as for exam purposes. But you won't be able to write everything what you have described in the theory paper, answer paper within the given time.
Yes, sir.
So I appreciate you for learning and writing all these things in detail. But your aim must be to prepare the answer such a way. First, you can present it like that, so that everybody will get an idea how to write the answer in your theory paper, and get your. You have to cross theory first. Then only you are going to come to practicals. So our first aim is to train ourselves to write the answers within the given time. Okay. So because you yourself admit that it took almost 2 to 2.5 hours. Of course, you have been reading and then assimilating whatever points you want in your mind, and then trying to putting them in orderly fashion. But that is not going to help all the PGs with the uh, third of writing. So I have a few questions here. You mentioned in respiratory system about the decrease in ERV, decrease in FRC. So in the exam, when you write, you have to give more importance to the decrease in FRC and the pre-oxygenation. Did you mention
Yes,
something, anything about pre-oxygenation here?
yes, sir. Pre-oxygenation, because of decreased FRC, there is more chance of
Yeah,
early desaturation.
yeah. What are the methods you are going to prolong the safe apnea period?
Ramping position will help to increase the period.
Ramping position
And
will help in
pre-oxygenation for more.
intubation. Huh?
Any other method of oxygenation?
See, the newer
Apnea,
techniques new, the
apneic oxygenation technique
hmm,
can be apneic oxygenation using nasal prongs even while intubating the patient can increase the desaturation, safer apnea time.
hmm.
And while pre-oxygenating, you can use CPAP, BiPAP, or PEEP so that it will increase the oxygenation and improve the safe apnea
CPAP or
time.
BiPAP, how will you administer? supposing you want to do a laryngoscopy, straight Macintosh laryngoscopy and intubate, or a video laryngoscopy and intubate, how will you apply CPAP or BiPAP?
During mask ventilation, you're asking, is it?
Mask you have already held and given pre-oxygenation with your
Yes, sir. That time we
anatomical
can
mask.
close the APL.
Huh?
That time
No,
we can
no.
close the APL valve.
You are not understanding. See, you are pre-oxygenating with the anatomical mask attached to the breathing circuit. 5
Okay,
minutes
sir.
of oxygenation is over. During
Okay.
which, after that, the induction is being done and relaxant is given. So at the time, either you can put a nasal prongs and give continuous oxygenation, or
Yes.
supposing you want to maintain CPAP, you push air with pressure. How will you do that?
Jet ventilation. Sir, that is
Jet
oxygenation.
ventilation.
That is oxygenation only, sir.
Huh? You have a
Yes,
nasal
sir.
mask. Okay,
We have another mask. We have some
CPAP
other
is
mask.
not given only
We
with
have
the
some other
face
mask.
mask. You have an
Okay, sir.
alternate, the nasal mask. So a tight fitting nasal mask can be fixed there, and you can give the CPAP through the nasal mask, while that you
Okay.
can give the laryngoscopy. Okay, so
Okay,
without
sir. Okay.
discontinuation. And HFNO is a separate method of giving the oxygenation.
Hypronasal
Right.
assistant.
So all these things, at least by one line mentioning, you should make. Okay.
Okay,
So
sir.
this discussion, this explanation is more important. Of course, you have mentioned all the pathological changes that is happening system-wise, from cardiac, respiratory, renal, liver, everything you have described beautifully. That is very valuable information for the postgraduates to learn. But from exam point of view, you have to highlight a few things, because what the question says, it's a clinical scenario case. A 42-year-old person with a BMI of 41, which belongs to the supermorbid obese condition, posted for with the diabetes mellitus, posted for gastric bypass surgery, which is a bariatric procedure. Maybe it is done for weight reduction purpose. Okay, so that is
Yes.
what is the first understanding we should have. So in that cases, always start with what are all the challenges you face in the anesthetic management of such patients. This I have been repeatedly telling. Whenever you are getting a case scenario case, start your answer with the challenges that you face. Here is a patient who is morbidly obese. That is the first challenge. So all the problems associated with obesity, starting from airway to IV access to complications, comorbidities, OSA, everything is there. They are immunologically compromised people. Easily they can get into pressure sore, they can get infections. So all that problem has to be first enumerated. The second thing is we have got diabetes also. So not even a word about mention about the diabetes condition you have said. You must first of all assess whether his diabetes under good control or not. You know, have you heard of Mr. Arun Jaitley?
Yes, sir.
Who was he?
Financial.
He was
Finance
ex-finance minister who died. No? He underwent bariatric surgery mainly to control his blood sugar, because his blood sugar was not coming under control with even 40, 50 units of insulin 3 times a day. Then because of that such resistant diabetes only, he was advised to undergo bariatric weight reduction. After that, diabetes came under very good control. So one of the indications for bariatric surgery is to control uncontrollable diabetes also. So when the question says patient is a DM patient also, you have to give some credence to that and write a few lines about whether the patient is a controlled diabetic or uncontrolled diabetic, what are the drugs he is taking, whether there are any chances of patient developing DKA with a high blood sugar. So those things have to be mentioned in your answer as a challenge. Okay, control of diabetes and its complication. And of course, then you go for the problems of laparoscopy in obese patient, because most of the bypass bariatric surgeries are done laparoscopically. Fourth chance is this may be done under robotic technique also nowadays. Okay?
Oh,
Any surgery which was done under laparoscopy, now they are doing it under robotic technique. So if robotic technique is being used, what will be the position of the patient?
deep pendulum back position.
So it will be Trendelenburg. Whereas in a laparoscopy, you can do it with a head up tilt.
Head
So
up.
the challenges of a obese patient, especially because this is a 40 BMI is a morbidly obese patient. So
Yes,
we
sir.
have to think of all the problems. So he will be very, very huge. Not we cannot imagine a patient like that. I think I was sending one uh, picture of a morbid obese patient coming for who is an asthmatic also, who cannot be shifted out of his house because the door was smaller than this fellow. So they brought him out, breaking the window through a crane, and he was 210 kgs in weight, and he has not moved out of the house because of this obesity. So such patients are also there. So 40 may be belonging to that category. Patient weight may be very enormous. Okay. So in that
Okay.
situation, what is sarcopenic obesity?
The fat, the muscle mass will be reduced, but fat will be
So how will you find
nutritional.
out sarcopenic obesity? So when muscle mass
Index
is
is
reduced,
there.
how will you
There's an index for that also.
find out whether the patient is sarcopenic or not?
Nutritional status assessment.
There are three things. A simple hand grip. Patient when he is in sarcopenic obesity, he is not be able to hold your hand tightly because the muscles are so weak. Number one. Number two, he has
Okay.
not been ambulating. He will be immobile. Okay. And third thing
Okay,
is his room air saturation will always be less than 95 because muscles of the respiration are also very weak. So with this simple clinical test itself, you can find out if the patient has not been moving about because of the heavy weight, his hand grip is very poor, and his room air saturation is always less than 95. That means he is in a sarcopenic state. Those patients carry a much, much larger risk than a patient who is able to ambulate, talk to you, go to the washroom himself. That patient is a much safer patient than a patient who is lying down in the bed all the time because he is not able to move. Okay? Right. So, you mentioned about OSA. In OSA, of course, you described everything. Apnea, hypopnea index, which all the exam they will ask you in the practical exam. Is there any newer tool to find out the severity of OSA other than polysomnography? What is a common tool that you use for airway assessment other than your routine Malambati and gyromental distance and mouth opening?
ultrasound.
Ultrasound, yes. Now ultrasound
mentioned.
plays a very, very major role in detecting OSA also by measuring the pharyngeal cavity measurement. Okay,
Yeah.
so that has to be included in your answer to get better marks. Okay, right.
Yes,
So
sir.
that also is important point you have to add. And which is the best method to assess the fat in the body? Is it the waist circumference, or is it the triceps fold measurement, or is it the what is considered as the best method of assessing the total body fat? Tesor Rao is there?
Waist.
Is there Tesor Rao? His name is there, probably. MRI or CT is considered as the best method of assessing the fat in the body. Okay.
Okay.
What is the
Okay.
importance of waist to height ratio? You said about waist to hip ratio. Is
Yes,
there
sir.
something called waist to height ratio, and what is the percentage or value which is considered as value which can cause complications or more risk in obese patients. Supposing, and what is the
ABSC.
waist to height
What?
ratio? It is if the abdomen is very protuberant and you take a circumference, you measure the circumference and divide it by the height in centimeters. Waist measurement in centimeters divided by height in centimeters will give the waist to height ratio. If it is more than 0.55, it is indicative of central obesity, and these patients are more prone for metabolic syndrome and sudden death. Okay? So if you get a morbid obese patient, you should not forget to write about waist to height ratio also, apart from waist to hip ratio. Okay. So that is another point you have to add. Right. You mentioned about the dosing. You have to use the lean body weight or the ideal body weight or the adjusted body weight. All the points are very well taken. Supposing patient has a hypotension and you have to use noradrenaline or adrenaline, which body weight you will use? Or if he has a bradycardia and you have to use atropine, which body weight you will use?
Predicted body weight.
For adrenaline and noradrenaline, it's ideal body weight.
Ideal
Okay,
body.
don't give it on total body weight. You have to give only on ideal body weight.
Ideal body weight.
Atropine you have to give on lean body weight, right?
Okay. Okay.
And you have to write something in this sort of cases about what is patient dignity, obesity and patient dignity.
Socioeconomic, psychological effect of the patient.
Socioeconomic and psychological. What does socioeconomic do has a role in this dignity? Nowadays we get patients who are very, very conscious about their, whenever they come for bariatric surgery, why they are coming for bariatric procedures? Because they are little concerned about their appearance, isn't it? They are looking so cute and uncouth, and so they want to look trim like other people and want to become less fat. So they have always a sort of psychological problem, some depression, and they don't want others to make fun of them. So to give a regular gown which, on admission, which a common patient uses, even one hand is not going in, how will the patient feel?
Demeaned.
Psychologically, definitely it will affect. Okay, so if a patient comes to a hospital, he should be provided with the dress or the undergarments of his size without giving him a smaller size and making him feel very awkward in front of others when he changes. Okay? So this is very important to prevent the psychological makeup of the patient getting shattered. And you must make sure that if the patient is ambulant, always try to make the patient walk to the OT and make him lie on the table by himself. But if in morbid obesity it is not able to do that, you must make sure that you have a stretcher trolley or a transport mechanism which can transfer this patient very safely without any chance of tripping and falling down or not able to lie on the trolley because of the inadequate size. So all that has to, these contingencies have to be planned well in advance. And your theatre also should be prepared properly to accommodate this patient. Okay. So
the problems are much more, no, sir, with the when they're doing an occasional case.
Especially morbid. That is why all these things you have to plan in pre-operative preparation itself.
Yeah, if they do it routinely, it's different.
Placing it in the OT Everything has to be planned well in advance. You must check whether you have a OT table which can accommodate the patient, especially this sort of super
Yes.
morbid or morbid obesity patients. Okay.
Yes,
So
sir. Theatre preparation.
that's OT preparation also. And
The airway,
you said about
that's what's airway. Airway, I don't think she mentioned the neck circumference. Did you mention?
Yes, ma'am.
You
More
said
than 40 circumference.
pretracheal fat, and the neck circumference. These are the crucial things that you have to look for
Yes, sir.
intubation. And extubation, you said patient fully awake, but do you have any extubation strategies? Would you like to use a tube exchanger or something before you extubate these patients? Because reintubation is going to be really difficult, isn't it? Yeah.
Yes, ma'am. Yes, ma'am.
why do you require RAM position? What is the reason for adopting the RAM position in a morbidly obese patient?
Same alignment of the sternum with the tracheoid, so the laryngoscopic view
Why you
will
are
be
not able to align it when the patient is in supine position?
because of the fat position and in limited extension.
The fat in the nape of the neck and the back. It will prevent the neck from being lining
Extension.
the extension. So that is the reason why you adapt them, not to just align the external auditory meatus to the sternum,
Yes.
because you are not able to get the correct smoothing position with the fat deposition in the nape of the neck and the upper, so in between the shoulders. So that
Yes.
is the reason for the adaptation of RAM position. Okay. And what is the current technique of TIVA? You said about mainly propofol only for lean body mass weight for induction and total body mass dosage for maintenance of TIVA. Is there any other combination of drugs?
Dexmedetomidine.
Dexmedetomidine and
Ketamine can
vitamin infusion. Yes, that is the preferred thing that is being advocated here. What are the advantages of the dex and ketamine combination?
the bradycardia of dexmedetomidine can be compensated with the tachycardia of ketamine and ketamine and the dexmedetomidine will mimic a natural sleep, so clear-headed recovery is possible with dexmedetomidine.
Possible, and ketamine gets a very good analgesic in low dose.
Yeah.
Okay?
Yes.
So without the emergency delirium problem, you have an excellent analgesia with low dose ketamine. So for many bariatric surgeries nowadays, the TIVA of choice is the combination of dexmedetomidine and ketamine. Ketamine 0.2 milligram per kg body weight per hour, and dexmedetomidine 0.2 microgram per kg.
Per kilogram per
milligram, that microgram. Ketamine 0.2 milligram per kg per hour,
kilo.
and dexmed 0.2 microgram per kg per hour. Okay? This infusion has been found to be very ideal for bariatric procedures. Very good. So these are all the points that I want to add, and you can just rewrite your answer in this fashion so that you can time and see whether you can finish it within about 18 to 20 minutes. Okay, so that you can accommodate all the points that you have to say. At the same time, you can keep up the time also. That is more important. Of course, what you have prepared is an excellent preparation for all those who have not read the chapter on obesity in anesthesia. She has given a very excellent gist of what are all the points you have to learn. So there is no doubt about that. But since we are training you all for theory writing examination, you should know how to concise these points and bring out the important points, adding the latest recent advances also in your answer, because many of the textbooks that you read give points which are written in 2008 or 2007. Even if you take the weekly tutorial or World Federation of Society of Anesthesia tutorial material, the topic on obesity is written in 2007 by one Dr. Roni. I don't think any updated version has come. Whereas BMJ has given a very latest 2020-22 updates on obesity, where all this inclusion of ultrasound for assessing the airway to rule out OSA, and adding this waist to height ratios for assessing the risk involved, the sarcopenic obesity, all these things are given in the current literature. So these things will be added only in the textbooks a little later on. But adding this to your answer will definitely bring you more marks, and it will be more appreciated. So you need not elaborate too much on that. You can just say the following systems are affected in obesity. So I would like to clinically and investigate and make sure that they are all not affected or affected to such extent. And don't forget to write about the risk involved in any surgical procedure case scenario they are doing. You must first take the history, then the clinical examination, investigation, risk assessment, optimization, then anesthetic plan, induction, maintenance, recovery, post-op care. These are all the headings under which your answer should go. Okay. So any case scenario, first the challenges, clinical examination, history, clinical examination, investigation, risk assessment or risk scoring, optimization, anesthetic plan, recovery, post-op care. If you write out and practice in this way for all the clinical scenarios, I think your presentation will be very nice, and it will, you can keep, because you know these are all the points that you have to write one after another, you will be able to complete the answer also within the given time. So instead of jumping from clinical examination to investigation and suddenly talking about drug dosing, and what about the fluids in this case? Did you mention anything about how to manage fluids?
Sir, intraoperative fluid of 10 to 13 ml per kilogram per hour is preferred. Liberal fluid therapy.
Fluids do you calculate on total body weight or lean body weight or what?
Lean body weight.
Fluids here, that is the challenge in obesity. You
Yes.
can't give fluids on total body weight basis. 10 to 15 ml, say for a 200 kg patient, you have to give 2000 ml per hour. Will you give like that?
No, sir.
So it is only on ideal body weight.
Ideal
Ideal
body.
body weight is height, height in centimeters minus 100 for men and 105 for women. So I think you mentioned that formula at all in your answer. Did you mention that?
I have not mentioned. No.
That is a very important point. Ideal body weight calculation is a very simple calculation which you have to mention in your answer. So some drugs are given only on ideal body weight. Okay. So fluids are also given only on ideal body weight. So that is a point which we have to include. Okay. Right. Otherwise, it was an excellent preparation, Dr. Ramu. Don't get disheartened by my comments.
No,
My
sir. No,
idea is to mainly encourage you people to train yourself to first clear your theory exam by preparing your answers to meet the theory exam demand. Okay. Right.
Okay. Thank you, sir.